Okay, can you see that all right?
Yes, we can.
Great, thanks. All right, so we'll start with this case. This is a 24-year-old with visual changes, and in this location, the vision change you would expect would be bitemporal hemianopsia, usually with mass in this location. So we'll look at the imaging here. This is going to be a T1 weighted technique. This is a post-contrast T1 weighted technique. So this is the anatomy. You can see that the mass is separate from the pituitary. So that's something you should file away. And this is how it looked on the coronal T1 scan. There were a few little areas of T1 shortening. So it's not completely homogeneous. And this is how it looked on the CT scan. This is without contrast. So let's see how this goes. So I'm going to launch this poll. Now, can you see that choices there?
Yes.
Oh, good. And then what do you press, like, what does it look like to you? Do you press a number or something?
It's like multiple choice.
But how do you respond? Do you just click on it?
Yeah, click on it and then I hit submit.
Very cool. All right, any more takers? Well, good, good. There's our 100%. That's what I like to see. So, excellent. That was a classic case of a craniopharyngioma. So to begin with, you see that it's separate from the pituitary gland. So we eliminate the notion this is of pituitary origin. You can see the elevation of the anterior commissure, and you can see the sort of displacement of the tissues here in the interpeduncular cistern. The enhancement is important, and it takes you away from the diagnosis of a Rathke's cleft cyst, since they should have no enhancement. So now you're left with this question of, could this be a glial tumor, let's say like an optic nerve tumor in this location? And I think the features that will help you here is these little loculated areas of T1 shortening are very typical for craniopharyngiomas. So whenever you see those, I mean, that should really get your attention. Rathke's cysts are usually bright all the way through and through. And of course, the calcifications in a young person, we know that in the youthful population, really the pediatric population, this patient's on the outer limits of that, of course, about 85% of the craniopharyngiomas are calcified. So this is a classic craniopharyngioma. Very good. All right. Now, can you see this next case?
Yes, we can.
Okay, good. So right, this is a 12-year-old, has a history of neurofibromatosis type 1, new headaches. The CT is obtained, but no calcifications were evident, so I'm not going to show that to you. So again, this is T1 no contrast, T1 no contrast, and of course, coronal scan. And I want you to notice the shape of the lesion. Make a decision about whether you think it's a pituitary origin or not based on the imaging. And what you see there is accurate. And this is what it looked like post-contrast. This is what it looked like on the T2 weighted imaging. I'll just go back and look at that again. 12-year-old neurofibromatosis type 1. All right. Okay, so here are your choices. Do you think this is another craniopharyngioma, a hypothalamic hamartoma, an optic nerve glioma, or a Rathke's cyst? This is great. I like, a little curious whether I could actually get this thing going. So again, these cases, as you can see, we're sort of following up on last week's talk, and feel like it was a good opportunity to see how you've incorporated that information. Good. Feel free to dive in. I don't know who's answering, so don't feel, got nothing to lose. Okay, so these are the results, and let's go through and analyze this case. So again, it looks like it's separate from the pituitary gland, so we're going to knock off the idea this is a macroadenoma, even though it has that so-called snowman shape, bulge above, a little bulge below, waist in the region of the diaphragm sella. That is not sufficient to make the diagnosis of a pituitary tumor. Now, the other feature is it's partially cystic, and it is partially enhancing. So the enhancement makes you think much less of a Rathke's cyst. Rathke's cyst shouldn't enhance at all. The homogeneous appearance on the T2 scan does look like a Rathke's cyst, so I certainly understand why you might think that way, but I think the solid portion also argues against that. The main thing here, of course, is always in the context of the history. We know that patients with neurofibromatosis type 1 are prone to form optic gliomas, and those optic gliomas are almost always pilocytic astrocytomas. And this proved to be a pilocytic astrocytoma at surgery. So again, this is the correct answer here is optic nerve glioma. So not a very common diagnosis, but oddly enough, you do see these in the NF1 group. Now, I'm not going to ask you about this case because this is really an oddity. Let's see. So here you see an area of, this is non-contrast T1, this is post-contrast T1, this is T2. So this seems to come out of the cella and grow up and sort of flip over on its side. Almost reminds me of those pictures of like the Phrygian gallbladder shape. And then you notice on the T2 weighted scan is that we have a lot of T2 shortening. You can see how this is of low signal intensity on the T2 weighted scan. Now that appearance is this appearance of T1, intrinsic T1 shortening and intrinsic T2 shortening is actually fairly typical for a Rathke's cyst. I'm not asking about this case because I think it's extremely difficult. Now this mass on CT had calcifications. So the simple answer is craniopharyngioma, craniopharyngioma, craniopharyngioma. But the piece of information that should get your attention here is the patient is 59. And so the pediatric craniopharyngiomas, they will have calcification most of the time. But the adult craniopharyngiomas have a different histology, and they usually are not calcified. So that's kind of a tick against craniopharyngioma. The homogeneous quality of it on both T1 and T2 goes against craniopharyngioma. You can't evaluate if there's enhancement. That's really a problem in this case because it's already bright on the T1 weighted scan. But as I mentioned, some craniopharyngiomas are intrinsically bright. So I think the correct answer here is to say either you think it's a Rathke's cyst, or you say, I don't know. But I don't think the correct answer is to say craniopharyngioma done. And this went to surgery and actually proved to be a Rathke's cleft cyst. So what the literature is telling us, and again, these cases are all from like last week. So I don't think I'm pulling these out of some, I just found out the path today. So, I mean, these are not like some part of my remote memory bank. So this is an important problem to deal with, but calcifications by themselves, particularly in adults, is not pathognomonic of craniopharyngioma. And there is, if you could Google this, that calcifications have been reported even with Rathke's cleft cyst. And the pathologist will tell you that there may actually be a continuum between Rathke's cyst and craniopharyngioma. So this is, the path here fell on the side of a Rathke's cyst. Now, just to show you how history is important, if I were to tell you that this was a 12-year-old with precocious puberty and seizures, and you were to see this mass, here it is on the T2 weighted scan, flare scan, post contrast, so non-enhancing, looks just like brain on flare, looks just like brain on T2, looks just like brain on T1, your answer should be hypothalamic hamartoma. But if I were to tell you the history, which it actually is, that this patient is the same patient we just saw, but 10 years later, after treatment of their pilocytic astrocytoma, then you would say this is treated tumor. So don't guess in these cases. You have to look at the history, look at the laboratory evaluation. If you have a question about the pituitary itself, look at endocrine function. But again, as a radiologist, you are, as I'm trying to point out in this case, the imaging can be very misleading, and there's an overlap in appearance of some of these lesions. So I tried to give you this simple run through last week, but obviously most of these things, it's more complicated than that. All right, here's a patient with new right-sided weakness. So I want you to look at these two images and tell me what you think is going on in this patient. Okay, so we're going to go give you another poll now. So, do you think this patient has an acute pons infarct? Do you think the patient has a lower medullary infarct, or do you think the patient has an abnormality of the carotid? All right, so we're divided here in opinion, and so let's the correct answer here is a left carotid abnormality. Now I wanted to show you this case because, again, like many things in radiology, the most important thing is just to have seen it. So most of you have probably not seen cases like this, but this is the internal auditory canal. Here you have the inner ear structures. You really shouldn't have any signal over here in the petrous apex. That's not because there's nothing there. It's because you have bone. Sometimes you have air. And in all patients, somewhere in here is the petrous portion of the internal carotid artery. Only in a normal patient, there's no signal there because of the property of high velocity flow that we get intravoxel dephasing. That's why on the T2 weighted scan, the basilar artery looks black. So on this side, this is the internal carotid artery. It looks just like bone, but the main thing is you don't see anything. But this worm, see this thing that sits here, it's very asymmetric with the other side. This is the petrous portion of the internal carotid artery. And the fact that you can see it tells you it's abnormal. Now you could be seeing it because of slow flow, and it can also be because it's thrombosed. And I guess the third choice would be it's dissected. But whatever it is, there's an abnormality here. Now, it's a little misleading because, they're kind of crummy scans. You have a lot of phase artifact coming from the sinuses here. So sure, I could be hiding something here in the brainstem. But I want to show this to you. This is a left carotid occlusion. I think this was from a cervical dissection. But look for that finding in patients who have new neurologic deficits, because it may tip you off, not so much that the carotid is occluded, but you may have a critical stenosis. And if the flow is not sufficiently quick, or the velocity is not high enough to give you this property of dephasing, you'll get this kind of slow river, sluggish flow, which you can actually see on MR. So anyway, get that in your mind. This is what you want to be looking for in patients with carotid disease. All right, here's a patient with, comes in, this is not unusual. Patient comes in, maybe there was like, they were, had prolonged unconscious spell, or maybe saw them have a few shaking movements, and they come in and it's called like, possible seizure or probable seizure. no one really witnessed that there was a grand mal seizure. And so on the imaging, they had a CT which was negative, but someone saw something on the left side. They got an MR scan. This is what it looks like. So in this young patient who may have had a seizure, may not have had a seizure, you have to make a decision what you're going to do with this finding. So do you think this represents a DNUT or a dysembryoplastic neuroepithelial tumor? I always have trouble with that, but I like DNUT, it's a little easier. Astrocytoma. Of course, we can have a variety of like pilocytic astrocytomas frequently have like a cystic quality, giant perivascular space, or a choroid fissure cyst. Well, very, very good, very decisive. So end the poll, share the results. Now let's go through this. So why should we think about a DNUT? Well, we know DNUT's actually one of the most common presenting symptom is seizures. So we should be thinking about that. And they tend to resemble cysts elsewhere. The argument against the DNUT is that it suppresses completely on the FLAIR scan. So remember that FLAIR, the reason that the CSF is suppressed on FLAIR imaging is because we are providing a pulse at exactly the point in time when CSF goes through the 0 point, if you think about that classic, three-axis model. So the fact that it suppresses completely tells you that this is completely CSF-like. Now, some low-grade tumors will look that way, but in my experience, DNUTs will have abnormal signal, look different than the CSF. So this is one of the features that goes against a DNUT. Now, in terms of the other possibilities, if we're thinking about like an astrocytoma, there really should be something enhancing. And I'm not trying to fool you. I mean, this is representative. So we have a non-enhancing CSF space in the medial portion of the temporal lobe. Now, the two things you should think about in this location are giant perivascular space and choroid fissure cyst. Giant perivascular spaces are usually seen a little bit more cephalate in the region of the inferior putamen. This is really right around, if you look, you're right at the level of the ambient cistern. Here you have the ambient cistern on the other side. Here's choroid plexus. This is where the choroid fissure comes through here, carrying like the anterior choroidal artery and so on. So this actually is a choroid fissure cyst. But if you call it a giant perivascular space, it doesn't really matter. It's a little bit of a semantic, well, maybe anatomic debate, but in terms of functional significance, it doesn't matter. Is that whatever this is, I think you should make the argument this is not the cause of the patient's seizures if he indeed has seizures. Okay, so perivascular space, choroid fissure cyst, coronal imaging usually is very helpful in that regard. I'm going to just show you a couple unusual cases. This one I want to show you, it's a little bit tricky, but it's unusual in the T2 scan to see all of the signal. You can see it's sort of coursing down here through the region of the internal capsule here all the way into the pons. And you see a little bit on the other side. And if you look on the axial scan, see this like lumpy signal there and here and here. You don't usually see this. And this is actually considered a typical finding in ALS. So it's one of the things you should look for. This is abnormal signal along the corticospinal tracts. But the fact that it's a little irregular, maybe that's sort of favors something else. And in this case, it turned out to be neurosyphilis. Now, this is the first case I've ever seen, which is saying something in a lot of years of actually proven neurosyphilis with imaging findings. That makes sense, I guess. So you're seeing probably some Wallerian degeneration of the corticospinal tracts in this patient with proven neurosyphilis. So a little bit off the beaten track, but again, if it should condition you to look in this area, particularly because you will get patients who are imaged for ALS. So this is one of the findings you should look for. I think